projection, the revenue projection for the community health center for their fees, it's considerably different. We went from 6.3 to 4.7. Much more realistic number in terms of revenue generation. So there's the biggest difference there. Under the total grants and contracts line in that column, that number, the 9.8, is slightly up from last year, but overall we're staying about the same with our total agency revenue, around 29.5 million. Okay, there's the document itself, the new cleaned up document. All the new revenue numbers are in for the year. If you look at the total agency revenue, 29,387.46, that's going to match the number that's also on your expenditure sheets that we'll go over. So those two numbers match. So there's kind of the preparation and all those changes that have to happen.
So, and as you finish up, maybe you can comment on some of the additional documents that made their way to the members as well.
Okay, yeah, and I guess I can talk about that right now. I'm not sure how it quite happened, but accidentally there were a couple of documents that got in there that you don't typically see. And the multi-page document, it looks like a worksheet. It's, I don't know, maybe 15, 11 pages. That's the document that I use every month to generate the report, your schedule of revenue. And basically it's just a humongous Excel spreadsheet, and I just track all the revenue, and I have to balance that itself. I balance that to the treasurer's report, and that's how I know that our funds are balanced, and it's reported to you monthly, and we're good to go every month. So a little bit of background there. The other document is a printout for the New World system, which is our financial system, and it's a printout that gives me all of the expenditures, and that's the report that I generate your statement of expenditures. So a little background information on the documents. I really don't intend to give those to you again unless you want them, but it's a lot of extra paper. So they went in on accident this time, you know where they came from, and if you have a question in the future, I can always bring my worksheets to the meeting if you want. Okay, so let's go back to the schedule of revenue. Let's talk about what happened in December. We did receive that small levy amount, but as I said, that would be accrued back to fiscal 13. Our total fees and reimbursables, we received just over 1 million, so we're about the 10% mark. Total contracts and grants, just over 446,000, bringing us to 4.5% of the revenue. Total agency revenue, we're at about 5.6. Just a little comparison, I did take a look at last year to kind of see where we're at. Last year, December of 2012, we were at about 4.9%. Okay, let's go to our statement of expenditures. For the month of December, the expenditures were just over 1.4 million. Now something else with this particular document that you should know, again, those numbers are going to change. There are salaries and fringe that were, for lack of a better term, expensed in December, but will actually go back into the previous fiscal year. That has not been done yet. Karen Hennessy typically does a cleanup. She'll be doing that later this month or early next month. Those expenses from December, from November will go back into the last fiscal year. So overall, fund total for statement of expenditures for December was just about 5%. Again, in comparison to last year, it was at about 6.4%. Okay, the last document is the capital improvement fund. Our beginning balance was $39,627.84. We only saw about $2.45 in interest, no expenses, and our ending balance remains just about the same at $39,630.29. Any questions on the?
Let the record show that the president is here, and he's going to lead the next question.
I apologize for being late. I think it's the first time, but whatever. I did have a question.
Sure. Okay.
Two things, the two items that were included behind the revenue section,
Yes,
I think that's too much information
Yes.
for us.
I explained a little bit, those accidentally got into Mr. Hines, I'm not sure how that happened. Those two documents are my working documents to generate those reports, and they won't be included in the future unless,
Somehow they were all paper clipped together and not intended to be distributed.
Okay.
that copy machine just kept going.
But you do know that we're looking at them.
Yes,
Yeah.
and which is fine, they are just worksheets, I do bring them with me to the board meetings, every month so that you know, so if you do have a specific question, on a particular revenue or whatever, I can try to best answer it, but they won't be included in the future for all of you. That's a lot of paper.
The other question I had was about the budget itself.
Mhm.
Are you gonna talk about the budget later on, John?
No,
Okay, my question is, with the revenue, it's the same as we had back in, 9/13, your report. And we had a lot of activity since September, I assume that's September 2013.
Okay,
On the final draft of the budget, V 2.3.
okay, I don't think I brought those documents with me.
Okay,
yet.
but anyhow, that agrees with the figure that we have in our revenue
Okay,
report, and we had an awful lot of activity with the union negotiations and so on and so forth, and I'm wondering if you are going to review that and make a change in the budget for this year based on what was decided at the bargaining table.
change with respect to the revenue or the expenditures?
The expenditures,
No, there are no new sources of revenue going into the budget that's been adopted at this point. What we do know is that there may be some expenditures
yeah.
that are lower moving forward. But we don't have absolutes on those yet.
Well, will we have somebody next one?
Well, it depends how specific you want to get. What line items are you addressing?
Well, the main items are salaries, fringe benefits, and there should be some changes in that, I would assume.
There are no changes because there are no additional appropriations that are coming from the county to address that. That will all be done internal.
Well, that's right. That takes care of the revenue, but I'm talking about the expenses. We didn't put anything in our budget for salary increases.
Correct,
We didn't put anything in the budget for the step increases.
correct.
And if there's any other changes with non-exempt employees, there's nothing in there for that as
Right.
well.
And
So there's three large items, I think,
Right.
that even though if we don't have the revenue coming in, we either have to show the expenses going to be spent, or we have to reduce in areas to show.
And that's the plan, are reductions. But when we say reductions, we're not reducing the appropriation in the line item. What we're doing is we're looking at things, we're looking at expenses that we won't be expending. So in other words, if we have something that's built in there that we were planning to spend, and now we don't spend it, that's a savings. But I don't go in and adjust the appropriation. That's fixed by the county.
No, I'm not talking about that, John. I'm talking about the total expenses, which is $26,883,295.
Well, it's actually 29 million.
Okay, I'm on,
This latest summary that Sue just went over,
Yeah?
that's the total budget. That's the total adopted budget. You're looking at last year, that's 2014.
All right, well, that's the point that I wanted to make.
I understand.
That we have three major items that we have to work on, and that's going to affect the expenditure portion of our budget.
Correct.
Or we have to make adjustments somehow where it equals the expenses of our
Right.
budget.
I understand.
Sorry I'm late and have these questions. Okay, are there any other questions on the treasurer's report? And I assume that's where we were.
Right, that's where we are.
Then I'll entertain a motion to approve the treasurer's report.
Second.
All in favor? Aye. Treasurer's report's approved. We'll have a report from the division, starting with Sue.
Okay. You have my report in front of you. Certainly, if you have any questions, I'd be glad to answer those questions. Just a couple of quick updates. Under the human resources section, I was informing you about a series of meetings and things taking place in order to comply with some of the changes in our newly ratified collective bargaining agreement. Stacy Whitehead, our program coordinator in human resources, and I have held two meetings so far, and we're holding another meeting this Friday with all the affected staff. It's about 40 employees total, and the meetings are going quite well. There's some changes for this staff in relation to their job descriptions and their titles, et cetera. And we wanted to afford them an opportunity to have a discussion, answer their questions, and kind of moving forward, make sure that we were all on the same page. Many of the managers, managers that manage the staff were not involved with the bargaining firsthand, and they weren't familiar with how all this took place. In discussion with Stacy, we didn't think it was really fair that we kind of burden the managers with doing this transition, so we're doing that with each of them, inviting those affected managers as well. So those meetings are going well. We have one more, like I said, on Friday, and I think it's going to be a very good transition for all the affected staff and the managers. Any
Does
questions?
anyone have any questions? There being no questions, move on to Dr. Troiani, please.
Did you have my three-page report in front of you? I just want to mention one of our licensed clinical social workers is retiring at the end of the month. We're sorry to see him retire. He's seeing about 102 Medicare clients, and we have no one that is licensed in that program to see those 102 clients unless we could recruit another licensed individual. And the problem there is I could have a counselor see those patients, but we can't bill. Medicare can only be billed by a licensed clinical psychologist as well as a licensed social worker. I also want to mention that because as we're migrating towards managed care organization contracts, they're telling us they want the providers to be licensed. The good news is that includes licensed professional clinical counselors. We've talked with the Department of Mental Health and the Department of Alcohol and Substance Abuse, and they made it very clear that when the Medicaid contract is being administered by the MCO, the Managed Care Organization, they go ahead and spell out the criteria. So as we look at our business model of providing those services, we're going to need to do some real shifting. I manage the MCO organizations. We're now at a point where we have very few grants. We're primarily fee-for-service. If we don't generate the revenue, or if I don't have the right people to generate the revenue, we're providing those services and not getting reimbursement. Again, this is a major part of the transformation of the system, which is expected to put at, well, the target is 50%, but they're looking at moving 80% of Medicaid into managed care organizations. The targets for the migration to managed care organizations are Cook County and the Collier counties. When this all started, Will County, as one of the Collier counties, got 2 managed care organizations, and more of those contracts are going in that direction. So in the next few months, within the next year, we're hoping to go ahead and get signed contracts besides the 2 current ones we have with those managed care organizations. I also want to report we had a meeting regarding closure of Tinley and reinvestment. Tinley Park, the sale of that land by law, and they've agreed that probably around $50 million will be reinvested back into the community. One-time reinvestment, not for salaries, but for infrastructure. We're coordinating an effort for the adult land, and we presented it to the MAP meeting this morning to come up with a unified proposal to include Trinity Services, Cornerstone Services, Crisis Line of Will County, and Stepping Stones, as well as the Will County Health Department, to come up with a proposal of how that money would come down to our organizations for infrastructure development. Since the Department of Human Services is not giving us 1 penny to develop a electronic medical record system, we're looking at that money being allocated, and we're going to request that money for that particular project. An electronic medical record system, as well as some hardware and technology to go ahead and support that. They're thinking that the distribution might occur, or a good probability of occurring, in 2014. The process is, once the allocation is finalized, they will put out a request for proposal, and Will County, the agencies of Will County, will come together and submit one proposal with the various agency sub-proposals there, and with letters of support. We're in a really good position because taking that approach last time wound up getting us a significant dollar amount for the launch of our adult crisis care system. And that pretty much covers my report. Any questions?
One comment, and that is that Dr. Triney and I have had discussions regarding what you heard earlier regarding the retirement of our licensed clinical social worker, and we're of the opinion that that's what we need to recruit for. We need to have a licensed individual.
Yeah.
So that's the strategy that we need to look at moving forward. Somebody that can replace the retiree and still be able to see the caseload and be able to bill Medicare. To do anything but that, we're going backwards.
Well, basically, we're providing the services and not getting a penny of funding. And there's no, unfortunately, Medicare will only take those 2 licensed psychologists and social workers, but they won't take licensed professional clinical counselors. And we don't see any changes happening there. But for the rest of the Medicaid population, the managed care organizations are saying that, and DHS is saying it's their call, they're wanting to see licensed people. And they have the ability to set that standard because they're at risk and it's their dollar. So it's a whole very different business model that if we are to survive, it's critical that we get in there and restructure to the new model that's in place. And the other part of it is we're now in competition. That is, we're no longer the only show in town, and for many years, the thinking was, well, who else is they're going to go to? There's even some, I shared with Mr. Cicero, there's a major, one of the largest mental health organizations that's in Cook County, that's in Kankakee County. They are looking at moving into Will County. They're a not-for-profit. They do a very good job, quite frankly, but they're exploring the possibility of expanding into Will County. So we're also in a very competitive environment.
Dr. Trani, do we have any employees that are eligible to become licensed, that we can look at a program, maybe we can assist them?
Yeah, we have individuals who have the degrees. Some of them are not licensed yet. Some of them are eligible to go for licensing, but they haven't. Some of them need that period of time before they could get licensed. So one of the things that we're going to do is basically take an inventory, look at those who are unlicensed, and see what can be done to encourage them or support them getting licensure.
Do they need more education or just,
They have the degree.
so all they need is experience?
Most of them already have the experience. What they have to do is to study and sit for the licensing exam.
Can we help them some way? Do they move to a different grade once they become licensed?
No. No, it's still mental health counselor too.
Maybe you should look at that.
Yeah, I think one of the things we really need to look at is, you know, at what point, again, we're kind of behind and everybody else has changed. And in many agencies, it's licensed social worker, licensed psychologist, licensed professional clinical counselor, or licensed marriage and family therapist.
I'll leave that.
We need to take a look at the inventory, we need to see
Yeah.
where everyone's at, what their skill sets are, what their degrees are in, what their experience is, and then kind of evaluate that.
And there's a lot of volunteer disaster agencies that require license.
Oh, yeah, they only take licensing. If you're not licensed, Red Cross won't touch you if you're not
That's
licensed.
right.
Yeah.
Probably the quickest solution to filling a vacancy is to hire a licensed individual.
Yeah.
And then you can look at perhaps other internal candidates achieving licensure down the road, and then they can become, you know, part
Yeah,
of
now,
it.
many of our staff are licensed. There's two things. There's the issue of licensed versus non-licensed, but there's also the issue of a particular type of license for meeting our Medicare.
And there's also revenue, which requires license, and that's the part that I'm looking at. I don't want to see us giving up revenue because we don't have the licensed individual.
Right. Under the business model that we're operating on, we're basically providing free services with no reimbursement, which doesn't make good business sense.
Are there any other questions for Dr. Troiani? Okay, thank you very much, Doctor. And we'll move to Mary and the Community Health Center.
Let's try this again. Good afternoon, everyone.
It takes a second.
I think it's,
Takes a minute.
It's ready.
There we go. Good afternoon, everyone. We are pleased to have Dr. Ehrman with us now. He started on January the 6th and going full speed ahead, already making changes and taking a look at the needs and what needs to be in place for us to achieve our goals for the year. And Dr. Ehrman will give a report after I do. Next, we have our Meridian Managed Care Organization, HMO contract that's ready for our signature. And I believe that's will be addressed later under John Cicero's report. This is one of 5 now that we are in contracting for. So just as Dr. Troiani said, this is the way of the future for us also. Our Medicaid patients are becoming required to join one of these organizations. And so had we, if we want to do that. Also, Mr. Cicero is going to speak about our dental fee increase. That was something that was approved by our governing council earlier this month. And he will go through that in detail with you. Dr. Garg is our medical director, or excuse me, our dental director. And when we had an on-site HRSA review a couple of years ago, it was recommended or required that we have our dental director be an employee and not a contractor with us. And so we have Dr. Gard's contract here for your review. She has accepted the terms. She will continue to work 2 days a week. It's not required that she do full-time. We also, when we took a look at our needs in our dental office, the dentists were spending their time cleaning teeth, and we had increased our services, as we talked about last time, to do scaling for periodontal disease. And that is something that could be done by a hygienist at less than half the salary of a dentist. And so we are proposing that we add in a hygienist for 2 days a week to start. We consulted with Dr. Streitz on a couple of meetings, and he concurs and recommends this also. And then we were happy in the middle of December to receive notice of award that we didn't even ask for from HRSA for additional funding for outreach and enrollment counselors. This is for the Affordable Care Act. An additional $85,000 that we are going to use to hire 2 more counselors to enroll our patients into insurance or in Medicaid or Medicare if that's required. Currently, we do try to see the patients as they come in, but basically we can just make an appointment for them to see the counselors at another time, and the counselors are backed up 3 to 4 weeks now. And then I did meet at the all-staff meeting with Dr. Troiani and his staff, and we started some discussions about how we can better facilitate coordination, communication between our departments, so that our patients can easily be referred and go to get their behavioral health needs tended to, and likewise, they can come to us in a seamless manner.
I have a comment that I think, having met with Mary and her staff, and a compliment of what a great job they've done, the time that they have researched this thing, as the fact as fees is concerned, and the fact of hiring a hygienist and getting, I mean, it's all necessary. It's all part of doing business and doing it right. I think it's well done.
How is this Affordable Care Act working? Are you getting a lot of people? Or?
We are, well, it was very slow to start, but now we probably had as many enrollments in the month of December as we did in the preceding couple of months. So they're seeing about 8 to 10 people in a day, and we've had quite a big response. More than 1,000 people have called in just for questions. Perhaps Thomas is here, he could give you the exact numbers. Do you have that?
Off the top of my head, the initial grant, we agreed to enroll into the marketplace or expanded Medicaid 600 individuals. At the end of the second quarter, which ended in December, we were 160 shy. So we have 2 more quarters to go. So we will far exceed the number that we said that we agreed in the grant that we would enroll. And we are approaching we have assisted close to 2,000 individuals to date. So basically we get credit for enrollment, assisted, and for individuals who we have work in contact with, in relation with other organizations. Right now we are working with Get Covered America, which is an organization that receives a sizable amount of non-federal dollars from philanthropic organization, and they agreed to do a lot of marketing for us. We have an enrollment drive which is going to take place in February the 8th, and we'll be working with Cindy's group as well as the counselors that we have to enroll as many individuals on that Saturday. It's going to take place between 9 and 3, and Get Covered America will be doing most of the marketing for us.
As I understand, about 85% of our patients are being enrolled in Medicaid rather than getting into the marketplace.
So 85% Medicaid, 15 goes to insurance companies. And do we ever know if they sign up with the insurance company, or we just get them to the point where they can?
Well, once they submit their application and to the marketplace, and that has been approved, the responsibility now is up to them to pay their premium or negotiate that terms in terms of exactly what tier they're going to fall in. I think they have gold, silver, and bronze. So it's going to be up to that individual because the cost increase depends whether you're bronze or whether you're gold. That's our responsibility ends once we get them into the marketplace.
You get them into insurance or Medicaid.
Right. And hopefully most of them, would go into the expanded Medicaid because that's more dollars for us too.
And then they become our patients. How many? Is there a high percentage?
That's the idea, huh?
Yeah.
Most of them are already our patients.
Oh, okay. And they weren't on Medicaid?
A lot of them may not qualify. Now, with the eligibility requirements changing, some that didn't qualify now will qualify.
Okay. Are there any other questions? Okay. Larry, thank you very much. Dr. Ehrman, do you have anything you'd like to say with us today?
Yes, I know that historically, I think my predecessors have given a report, which is entitled, and it's part of your package, I think it's in the middle, called the Divisional Statistical Report. And I'd like to not go over the details of it, other than you'll see that there was definitely a decrease in terms of numbers of encounters and visits. And I think this has to do partly because of the strike that happened. So I think there were 3 or 4 days in the beginning of December where that was still going on. And also because the way that we're presenting these statistics to you is only really limited in terms of its usefulness. So what we're going to be doing starting next month is to give you much more, I think, better hard data. And so we're going to actually present productivity figures to you. Because what we have to really do is to see how many hours in total our providers are there seeing how many patients, rather than just total encounters. So it's not, we're not going to stop giving you total encounters, but we're going to be able to show you month by month what real changes there are in terms of the productivity of the providers. So that'll be one change. And then the next change will come the month afterwards, where we're going to present the quality indicators. And I don't know how much Dr. Kaler presented this to you, and I won't go into it in depth. But there's 2 basic sets of quality indicators that are very important for our health center and every other federally qualified health center. One is with the federal government, and that's called UDS, which stands for Uniform Data System, and the other one is through the Illinois Health Connect, which is a big pool that's related directly to Medicaid. It's to our interest to show that to the Board of Health and internally to the entire staff, because if we go above a certain number, a certain percentage on those indicators, we actually get money from both the federal and the state government. So we'll be presenting that also by the time March rolls around. I don't know if there's any questions about the statistics. There's just a couple other items.
Well, the only question I have, Doctor, is that I understand that the strike could reduce the number of patients coming in and so forth, but I don't understand how it could eliminate the number of deliveries. nature takes care of that. And
Does everybody have some revised numbers at their desk? There should be a new packet, John.
Well, the deliveries went up.
The deliveries went up 31%.
Okay, well, I didn't have the revised, last year it was 68, and this year it's 60. The one I got was 38.
It's the move, John. It's the move.
Yeah, December 2012, just to clarify, there were 32 deliveries, and then December 2013, there were 42 deliveries. So it actually went up by a little less than a third. But the reason this report has limited usefulness, for example, if a provider gets sick, or goes on vacation, or goes to a conference, you wouldn't know that by looking at this report, because this just counts the number of encounters. So that month, compared to the month before, where nobody got sick, or nobody went to a conference, that month will look really bad. So that's why, starting next month, we're actually gonna give you the actual number of encounters per provider, so that you have a much, we're not gonna name the providers, but we're gonna do it globally. So all the providers, and then we'll take all the visits, and we'll give you the actual productivity numbers.
Doctor, what I would like you to do, if you've got some ideas of a new format, is in lieu of replacing this for February, it can be in addition to
Right,
this.
that's,
Let the board weigh in on it. If it's a format that they would prefer, then we'll go with that.
yeah, I think this is useful, don't get me wrong, so it was never proposed to replace it, it was in addition to it. So we'll put it in a format that hopefully it'll be clear to everybody, and we would appreciate any feedback you get. There's just a couple other comments I want to make in terms of what Mary said about what we're trying to do. The major emphasis, beside the recruitment of new patients, and we would really encourage all of you to send anybody either to the 4 navigators for the Affordable Care Act that are through the Will County Health Department, or to the 2 people in our clinic, which will soon be 4. Because it turns out that the latest data shows that in the whole state of Illinois, almost half the people are actually enrolling in the expanded Medicaid program. So in our clinic, about half the people at least are uninsured before the Affordable Care Act, and about half of them, or a quarter of them, are eligible, it appears to be, and we'll have those statistics coming in the next few months, are really then eligible for this expanded Medicaid. So what that means in terms of dollars and cents is that on the average, maybe we're getting $25 at the most for those half of the patients that are uninsured now, if they pay at the bottom of the sliding scale, which the vast majority do, not just in our clinic, but throughout the country, and these types of clinics, we would get about $133 for doing exactly the same thing. So that's a tremendous increase. So that's why Thomas and I are working with the counselors, even with the security guard and everybody else, to do what we call continuous point of contact. So everyone that has contact with the patients and their family are going to be really pushing this idea of trying to get involved in getting them expanded Medicaid or insurance.
Okay, maybe we should refresh our minds what other providers at Silver Cross represents.
Other providers at Silver Cross, from my understanding, and Mary knows more at this point than I do, so we have providers who are, I'm sure people have heard this term in the last couple of decades, called hospitalists. So there's different types of providers, primarily in OB-GYN. So we have a person who covers for our OB-GYN doctors during the day so they don't miss clinic. And that's a Silver Cross provider who then would both do deliveries during the day when our doctors are in the clinic, and they would also do rounds on our patients who were delivered overnight by our doctors. That's a program that's somewhat a joint program with Aunt Martha's.
That's right, that's what I was saying.
Right.
That's the cross coverage agreement that we entered into with Aunt Martha's, where they will cover the deliveries for us when our providers are here in our office and vice versa. So that's what that really is representing.
So what I'm getting at, Doctor, is that the total deliveries for the month of December was 60. And last year was 68 of our patients. So at the top portion of this statistical report, it shows us doing 31% higher than last year, and down below, actually, we were lower than last year, using our contractors and so forth. What we want to do is to see what our productivity is with deliveries for all people that are delivering our patients.
Very good.
Okay? Isn't that what we want to see, John?
Sure.
All right, thank you, Doctor.
Thank you.
And welcome again.
Thank you.
And now we have Elizabeth.
All right, hopefully you have my report in front of you. I just have, actually have a couple things I'd like to add. First, I'd like to introduce Carmen Stanford. She is our intern currently. She started in November. She's from Governor State University, and she's a community health major. So welcome, Carmen, and thank you for all your help. I also, I'm assuming you saw from the revenue being brought in, you see that we are still bringing in our permit fees for food and discharge bills. And I want to publicly thank my staff for all their hard work on receiving and following up to ensure that these permit fees are paid on time. Our food invoices were due by December 31st at midnight, and we did unfortunately have some individuals that did not pay on time. So there was some penalties accrued, and then we did have some facilities that we had to go out and knock on doors to ensure that they did have their permits for 2014, and that has been taken care of. So once again, I want to thank my staff for that. Further down in my report, it has finally happened. The US EPA has issued the general permit for discharging septic systems. It has been on our minds for years, and it is going to become effective on February 10th of 2014. This is a major change for us. We will not be able to issue construction permits for discharging septic systems until the homeowner or owner of the property secures an okay from the US EPA. So we have been getting in touch with our contractors. We've been sending out the information to them that we've gotten from the EPA. The other point of concern is that permits that are in place right now but not final need to be final. These discharging systems have to be installed and operational by February 10th. So we do have some homes that are out there that are not completed yet. So we are in touch with the owners.
Is there any assurance that the US EPA will issue these permits for the type of systems that are being installed in Illinois and Will County?
No, you have to prove multiple things in order to get a discharge permit. One of the things you have to be able to prove is the sewer's not
It's the
available.
last resort, right?
Correct.
This
It
is
has
the
to
bottom
be
of the list.
The last resort, no sewer.
Right.
There can be, technologically, there is nothing feasible to go subsurface. And you have to prove that through soils, through topography, through engineering, and different things like that.
Is the homeowner gonna have to hire someone to certify all these things, or is that, we expected to do that here, or?
We are not expected to do anything in regard to this permit. It is all driven by the US EPA, enforced by the US EPA. We are not part of it at all.
We can't issue any permits until the homeowner has obtained that permit from US EPA, right?
I would prefer not to, because if the US EPA denies them a discharge permit, they have to go a different route. So what we have said, and even in NIPIC, no one is going to be issuing permits until they know for sure that they've gotten a permit from US EPA. They can come to us and get a construction permit.
Right, we don't want to have some legal ramifications that the health department says is okay, I did it, and then the EPA says.
It could take EPA years to do that.
Well, no, they have 30 days to
30
turn around your
days. It took
application.
them 10 years to figure out how to do this.
So, they have 30 days. So you have to submit
Trust your government.
a lot of information.
I'm glad I'm not getting a permit.
Are the contractors have to do this, or will be the contractors doing all the individuals?
I do not know who is going to help the homeowner make their submittal. It is arduous, and there's a lot of information. They do have to have a soil scientist do the soil report if they're going to prove that you can't install subsurface. So it is gonna be very difficult, and I believe they're gonna need the assistance of their contractor, a soil scientist, an engineer, somebody to help them through the submittal process.
Are you envisioning that many people who have approvals for their lot for a mechanical system may come to you and say, what other options do I have, because they don't want to go through that process?
Correct. And that's the main intent. Actually, the US EPA basically is saying their intent is to push people towards subsurface. You know, the state code just changed where you can put in a curtain drain, you can alleviate seasonal high groundwater, you can put in smaller systems. So I think they're really trying to push those individuals to putting in systems that are subsurface. And the EPA even says, you know what, we have new guidelines, it's only 100 gallons per waste a bedroom versus the state code right now says that a normal home generates 200 gallons per bedroom. Well, the US EPA says, no, it's only 100. So they're trying, basically they're saying, you know, we can figure out a way, we can engineer a way subsurfacely on most lots, is what they're basically saying.
Well, what you might end up with 5 years from now is more failing septic systems.
Yeah, we don't know. At this point, I'm just,
I mean,
I am.
let's look at the soils in many areas of the county are really unsuitable for failing systems. They can't get a mechanical, which was the alternative for bad soil. So now we say you use less water for a smaller system in, and 5 years from now it fails.
Our biggest concern is the people that have permits right now that they're either not installed yet, because they are only given them until February 10th. After that, if you have a permit, even from us, if it's not installed by February 10th, basically, we are not going to be able to honor that until they go to the USPTA. We did meet with 2 soil scientists yesterday, Brian, myself, and Stacy, because we wanted to start asking these questions. What are some other things we can do? And we did get some good information from the NRCS. So, you know, we're going to have to see how this all plays out. We are hoping, though, that we will be the lab that maybe when they do sample these systems, they can bring their samples to us, because we will not be sampling them. This is completely US EPA, and our samplers don't meet the qualifications to sample these systems.
This is for all new systems. The old systems stay under the old.
Right now, the old systems are still under our jurisdiction. We'll see if the Illinois EPA comes out with a permit in the near future. But it does include repaired systems. So if you have a current existing system and you need to replace an aerobic unit, you need to replace a media filter, you now have to go to the US EPA to prove to them that a discharging system needs to be on that lot.
Will we still be able to bill for the permit to discharge on any of the new systems that are covered?
No, we have no jurisdiction over the US EPA system.
New ones, but
The new
we did
system.
receive some assurance that our old permitted systems, that they would do nothing to stand in the way of us inspecting and collecting
Yeah,
samples.
but what's gonna happen, you're gonna get an erosion.
It's gonna stop,
Because
it's gonna
if somebody
stop
puts in a
growing.
new aerator, or puts in a new filter.
We will lose those because they will then be under US EPA.
Who inspects the new systems that go in, US EPA or us?
No, well, they'll get the okay to install them, they'll still come to us for the construction permit, so we'll still be doing the inspection of the initial system, you know, when
Talking
it
about
goes
the
in.
effluent testing in the future.
But the effluent, the homeowner has to ensure it's done, they have to hire a contractor, they have to do it themselves,
Don't we charge for the first year of permit to discharge when we issue the permit for system?
we wouldn't be able to do
We
that.
wouldn't be able to do
No.
that.
Back that far up.
So you're gonna have some revenue issues here.
I mean, there's very few discharging systems going in right now, but there are repairs. And that's where I think we're gonna be losing, because as they start to age, they will have to be repaired, and they will have to go to the US EPA to get their permits.
To what extent do they define a repair?
Major component, aeration unit, a media filter,
Putting in a new chlorination system?
that, they said, would not be a repair.
Still gonna see an erosion over the years.
Correct. So that's a big impact to our department at this point. I have been in touch with them a lot because we're one of the, obviously, we're probably the only county in the state that has a lab that does the sampling, and I've invited the US EPA multiple times to come out and sample with us, and at this point, they still have not, agreed to come or had time to come, but I still would like them to join us because it is gonna be, it's gonna be in their permitting and their enforcement. One of the other things, Radon. It is National Radon Action Month, and Vic did put out a press release, and we also got an article that came out today in the Herald News regarding radon. And lo and behold, I think we sold 10 radon kits already today. So thank you, Vic. We do have quite a few still on hand, so if anyone does need a radon kit, please stop upstairs or go to the branch offices and get one. And one other thing is we just received, I think it was yesterday, an agreement to be an agent with Illinois Department of Public Health to inspect the swimming pools. We've always been an agent for them. We've had an agreement, I think that dated back to the 70s. They are coming out with new agreements, so we're going to be working through that. The agreement has to be signed by February 28th, so we're working through that right now. Other than that, I think that's it.
Couple of ordinance revisions coming forward.
Correct. We are in the process of revising the sewage ordinance in lieu of all the changes, and the
The food.
food ordinance. Yes, I'm like I have all these ordinances around through my mind, and the food ordinance. So hopefully they'll be before you in the next couple of months.
Busy.
All right, thank you.
Elizabeth, has there been any interest in fracking in our county?
You know what? We've talked about it in Nippick, but they haven't been focusing in this area. And I know Larry from Winnebago County has been very active in following the legislation regarding fracking, and then of course down south. But I haven't heard anything at this point in our area.
Does that stay within the state responsibility like other states are doing?
Well, they're working on the regulations currently at the state level.
Then I guess my second question is, are we in good terms with the mayor of Bolingbrook?
I believe we are.
Did someone contact him?
Yeah, we did.
Thank you.
You're welcome.
Hi everyone, I just wanted to point out a couple things on the statistics page for me. We did add the in-person counselor statistics in, and you can see we had 85 Medicaid applications and 30 Marketplace applications for the month of December, which was kind of still a little bit of a short month between the holiday and the strike. So that's what we had, but they did have 950 calls to the hotline. So all 950 were contacted and assisted in whatever way, whatever they had needed. But some people just contact us to get information, and then they go online and do their own thing with their own computers. So the other thing I wanted to point out is all the zeros on my statistics in the tobacco program. We do have an open position, and I think all of you know historically tobacco is never not busy. They are always busy. But we do have an open position, so there's a couple statistics that that weren't worked on. The number of tobacco or smoke-free policies implemented, that is so misleading to have a big zero there, because they are actively working with many partners on technical assistance for developing tobacco policies. But in order to actually change a policy in a business or a municipality takes months and months and months. So what we were going to request, if it was okay to do, instead of saying next month, instead of saying number of tobacco and smoke-free policies implemented, if we could change it to number of partners provided with technical assistance with developing a tobacco policy, it would show the work that they're actually doing as far as the number of businesses or landlords or schools or whatever they're dealing with. It would better indicate what they're doing instead of having 3 zeros there. So we're asking if that would be okay to change it to that. And for our grant policy, for our grants, we have to actually have it that way, but it doesn't reflect it on a monthly basis. So we will, if it's okay, we'll just put in that number of partners provided with technical assistance. Any questions?
Thank you very much.
Okay.
We'll move on to Jackie.
Yeah, I'll make this quick.
Basically, you have my report in front of you. We have been in the process this fall and the last month and a half of getting all of the memorandums of understanding on our Phase 2 and Phase 4 partners. It's about 50 partners. And I'm happy to say we only have 2 to go. 2 to go. And we had all of them in within a couple of weeks, other than maybe 10 or 11 stragglers. So we've got them all in. And that's a big accomplishment because obviously getting an MOU signed is probably the last thing on some of the agencies' list, you know, because they have so many other things to do as well. So they did a good job. Our first responders, we did a call down drill to them, and there was a text message drill that we did on 12/20. And we had 100% acknowledged the receipt, and then again, 100% were able to report at the given time, at the designated time. This is a big accomplishment because, as you know, our phases are set up with our red agencies. I contact EMA, they do the text message out to those 5 red agencies, and then they call all the blue agencies. And all that has to be documented back and forth between them and then sent in to me. And they did a great job. So our Medical Reserve Corps call down that we did a month or so ago, we had about a 64% acknowledgement rate. We did it in the evening thinking we could get a better rate. They must have all been to dinner because we didn't. It went down from when we did it during the day. So I don't know what happened. So that was kind of interesting. And we now have, as of last night at 5:30, we have 212 MRC volunteers instead of 210. Family Health Services has set up their training date. We've already completed behavioral health and environmental health for their annual SNS update, and we're still waiting to set up administrations and community health center, and they'll be setting those up soon. We're having all of our phases start to come in. Invites are going out this week and next week for our annual updates with all of the different our partners in the plan. So that's it.
Any questions? Thank you. In looking into Vic's report, I happened to see the Community Health Center ABC bit about reading. I don't know if anyone else saw that, but it was very good and made the Community Health Center look very good as well. John, you want to handle the old business?
None. I love those. Great topic.
Okay, we'll move on now to the new business and resolution 1401. And this is a resolution for connection components for Envision Connect application upgrade, $18,000.
I would ask Elizabeth to tell us what we're doing.
Envision is the environmental software that we currently use, and we've been using it for several years. We are upgrading to Envision Connect, hopefully very soon, so this is the first step. And this includes the Envision Connect license, the monthly fee, and the inspector fee. So that comes out to be $17,100.
Questions?
Second.
Moved in second, all in favor? Aye. Opposed? Resolution 1401 has been approved. 1402, approval for the purchase of West Nile virus program larvicide. And this is you as well.
Yep. As you saw in my report, our West Nile grant did get reduced a little bit, but what I've done every year is I save our larvicide money. Our grant goes until March 31st every year, so our new grants always start in April 1. So currently I'm in my current grant year, which I typically save my larvicide money until February or March so I can order it, so when they come in for our seminar at the end of March or beginning of April, I can give all the municipalities their larvicide. And that's going to work out perfect this year because our grant for next year did get reduced. So this year I'm going to be able to purchase the larvicide that we can hand out to the municipalities, and hopefully that will take care of the 2014 adequately.
Questions? Move? Second? All in favor?
Aye.
Aye, opposed? 1402 passed. 1403, approval for the community health center minimum dental fee adjustments. Are there any questions on that?
I would ask Mary to give an update of the 3 changes and the process that you went through.
The first thing we did is we did a survey of the dental clinics and the FQHCs in the Chicago area. And we found that we had been charging $30 per visit regardless of what kind of service had been provided or the number of services that were done. So if there were 3 fillings, it was still just $30. And so what showed from the other clinics that we contacted, they either charged $50 per visit or $50 per service. So for 3 fillings, that would be $150 for that visit. And as far as extractions go, they charge a minimum of $100 per extraction, some $150 or more, some as much as $350. And so, in order, our dental division has always come in at a deficit. We have spent more money than we've actually taken in. And lately, it's been because the Medicaid is no longer paying for dental care for adults. And that means we have a far greater percentage of adult patients than we ever did. Last month, we had 56% of our patients were adults. And in the past, it's been, was 25, 30%. So that means these adults are paying this minimum fee versus the Medicaid rate we're getting for kids at $97 per visit. So that really affected our bottom line, getting more adults in there. So we propose that we change our minimum fee for those who apply on the sliding fee scale to $50 per visit. And last month we was approved that we could do add in extractions. And so we propose to charge $100 per visit for an extraction, even if there are 3 teeth that are extracted at that time. And for fillings take a lot more supplies and dentist time, and so we propose to increase that to $75 a visit.
And Mary worked with Dr. Streitz on this. He had some input and evaluated their proposals.
And the work they did was excellent, I think. We talked about it for quite length, and I think this is more than fair. And as you know, I think our role in this is to help those that can't pay a lot for things, but yet I think we're going to be able to handle it. And we need a hygienist badly, and another dentist. So we got to increase the fees. We can't exist otherwise, or don't do it.
Well, didn't we have a audit not too long ago where we were told that we couldn't have people come back for additional dental work? If they needed 3 things, we should do it in 1 setting as opposed to do it in 3 settings and charging 3 times.
I don't know who makes those. I think the office has to make that determination. That's something from the outside. I mean, how do you know, John, you get in there, what has to be done to do it?
Yeah.
I really think they've done a real good job of this. I don't want to break any laws.
No.
But I really feel that it's been looked into, and I really think it's fair.
They were expecting us to do 3 things for $30, and now it's reasonable that we do 3 things for $75 or $100. I think it's a reasonable resolution. Are there any other questions?
I'm gonna go there next week. That's a good deal.
Okay, second? Okay, Dr. McDonald, all in favor? Aye. Opposed? That's passed. 1404, approval for the minimum Meridian Health Plan Illinois Practitioner Agreement.
I would just like to comment a bit about this. In the old days, having a contract with an HMO meant that you got $3 or $4 per patient per month. And then the idea was to keep the patient out of getting care as much as possible. And now that's no longer the case, but rather they will reimburse us at the Medicaid or Medicare rate for each visit. So this is to our advantage to enroll with them, and they will send more patients our way, or at least that's the idea.
And the goal is to keep them out of the hospital.
Yes.
That's the new goal. And I would also say that we may be coming back within another month or so with a similar agreement with Meridian for behavioral health services. So we're kind of tag teaming both of our clinical services here, our two programs, with these various HMOs.
Have you calculated how many new patients you may see as a result of this agreement, or are these existing patients?
No, none of our existing patients are enrolled with HMOs, but we do know that they're going to be required to pick an HMO. And if we don't get enrolled, they're going to pick somebody else. No, but I'm sorry, I don't know how many numbers it would be.
Okay, I'll entertain a motion to approve this.
So moved.
Second,
Sure.
Mr. Brandolino, all in favor?
Aye.
Opposed? 1404 is approved. Resolution 1405, appropriation of funds, dash outreach and enrollment assistance security grant supplemental funding, $85,536. This is the one that came that you weren't expecting.
Yes, that's right.
Are there any questions on this? Entertain a motion to approve.
Move.
Mr. Gould, second. Chief Forsythe, all in favor?
Aye.
Opposed? Motion's approved. Resolution's approved. Okay, next item is ASME Step 3 grievance, and we'll let Mr. Cicero lead us into that.
Here's your documentation, John. I think everybody should have,
Everybody have
everybody have this at their desk, Stephanie? No, to the board members? Everyone should have a memo on county letterhead that's from Joy Yasko, Union Stewart, Local 1028, along with an attached copy of a Step 3 grievance that's being presented to the Board of Health. The other document that you have are just some historical background information about the grievance process. And I guess at this point, I want either Mr. Delrose or Mr. Kluger to present information to the board. And I guess I'll ask our state's attorney for clarification with respect to information that we talk about with respect to the grievance being in open session, closed session. I'd like to get.
It's our opinion that an open session is more appropriate, or that it would be appropriate to have it discussed in an open session.
Will you be referencing any specific individuals or employees? That,
And that is obviously one of the concerns. As long as there's not going to be a discussion regarding any individual or any specific person, then we think it's appropriate to do that in open session.
Is this an item we may want to talk in closed session and come back out into open session?
I would agree. I can't, in the course of the discussion, I can't guarantee that there wouldn't be any mention of any particular employee. So in the past, when we've had we haven't had hardly any Step 3 grievances that go into the Board of Health, but in the past, they've always been done in executive session.
Well, certainly if there's going to be a discussion that references any specific employee, then it's probably more appropriate, obviously, to do that in closed session. But I wasn't aware that we were.
I'm not necessarily saying there will be, but I can't guarantee there won't be, depending on discussion going back and forth.
Did somebody's name won't come up?
Yes.
Okay, why don't we,
That would be the controlling
Mr. Dale Rose, why don't we talk about this in closed session and come back? And now I'll have to ask you, John, who are you going to invite in closed session?
well, I think, for the most part, our directors can stay, and we'll excuse the audience, other than Dave, Joy, and Joe. No, I'm sorry, Stacy Whitehead is behind Joe. And who else? Just Stacy. Okay.
Okay, so at this point in time, I'll entertain a motion to go into executive session and discuss personnel and legal issues.
So move.
Second. Anybody want a second? Mr. Selko. A roll call, please.
Mr. Hines,
Yes.
Mr. Brandolino,
Yes.
Mr. Melko,
Yes.
Ms. McDonald,
Yes.
Mr. Forsythe,
Yes.
Mr. Gould,
Yes.
Dr. Strike,
Yes.
Dr. Comanduri, Dr. Rudman, Mr. Cornelius,
Yes.
Mr. Babbage, Dr. Terrell,